Good morning, everyone. Today I am Dr. Pianshi Seni, and my moderator is Dr. Mankaran Sandhubas. And today I'm going to present on the topic of Neutraceuticals. So it seems to be a tough word, but let's split the word and understand what does it mean. It means nutrition plus pharmaceuticals. So these are basic food components or active principles which have positive effect on our health and quality of life, including preventing and treating disorder. So some of the nutraceuticals are used in the following areas of psychiatry like depression, bipolar disorders, schizophrenia, OCD, anxiety disorders, post-traumatic stress disorders, and autism. These are some mentions of nutraceuticals that we are going to study further. That is St. John's wort, omega-3 fatty acids, folate, vitamin B12, kava, and valerian. Let's talk about St. John's wort. Uh, it is helpful in Hindi. It's a herb which is found in the areas of Himalayan region. It is a mild serotonin reuptake inhibitor. It also is helpful in anxiety and it works by action of enhancement of GABA receptors. The omega-3 fatty acids, some of the sources of omega-3 fatty acids like cholesterol, soybean, and these omega-3 fatty acids are helpful in bipolar disorders, depression, and schizophrenia. What are the function of this? Omega-3 fatty acids helps in the maintenance of neuronal membrane structure. A recent study have shown that these are helpful in prevention from transition to psychosis, but the evidence is of low quality and conclusion is unconfirmed. So polyunsaturated fatty acids is now not recommended apart from their beneficial metabolic effects according to Maudsley. Some of the sources of omega-3 fatty acids that we can see on the screen. So these are chia seeds, flax seeds, kidney beans, and let's talk about folate. It helps in formation of S-adenosylmethionine, and the lower folate levels show poor response to selective serotonin reuptake inhibitors. And folate is helpful in treatment of depression and even improves cognitive function. Approximately 500 microgram of folic acid is used, but drawback is seen that higher doses may lead to skin reactions. Vitamin B12. Vitamin B12 is a deficit associated with subacute combined degeneration. But recent studies have shown that mild deficit of vitamin B12 is associated with depressive symptoms. So it also helps in improvement of cognitive function. And some good sources are fish, meat, eggs, dairy products. S-adenosylmethionine. It is helpful in treatment of depression and it functions by transmethylation reaction, which helps in formation of important neurotransmitters like epinephrine, norepinephrine, and dopamine. Some sources of methionine are eggs, milk, soybean, alpha-lactalbumin, and it is a whey-derived protein, and which is found in sources like milk and cheese. It functions by increasing the level of serotonin and improves mood and also decreases level of cortisol in subjects who are vulnerable to stress. Inositol, it's a carbohydrate which mediates signal transduction, and its role have been seen in depression and ADHD. And sources of inositol are oranges, melon, and brown rice. Some good sources of inositol that we can see on screen. Kava. Kava is a traditional beverage that is basically used in Kashmir, and it's helpful in relaxation. They make the tea out of kava roots. It's a herbal medicine used there. Valerian is also a herb that is useful in insomnia and anxiety. And this is passion flower. Its Hindi name is Krishna Kamal, and it's used in anxiety, and its action is sedative and antidepressive features are also seen. Some of the nutraceuticals that are used in headache are riboflavin, coenzyme Q, magnesium, vitamin D, melatonin, and ginkgo. Nutraceuticals in cognitive decline are flavonoids, tannins. They are found in tea. My references are from Maudsley and published paper. Thank you. Thank you. Yes, ma'am. Okay. Thank you.
Good morning to all. I am Dr. Rishit Garg, and today I'll be talking about antiepileptic dosing for seizure disorder and mood disorder. My moderator is Dr. Anusha Agarwal. Firstly, I'll be talking about the classification of antiepileptic drugs, which include barbiturates, hydantoin drugs, deoxybarbiturates, aminostilbene, succinimides, aliphatic carboxylic acid, benzodiazepine, phenyltriazine, cyclic GABA analogs, and some newer drugs. First drug is valproate, which comes under the class aliphatic carboxylic acid. Valproate effectively treats mania and stabilizes mood in patients with bipolar disorder, principally used in absence, atypical absence, myoclonic and focal onset atonic seizures. Its half-life is about 15 hours, and it acts by enhancing inhibitory neurotransmitter and modulating voltage-gated ion channels. For dosing in seizure disorder, we give 20 to 60 mg per kg in adults, and in pediatrics, we give 15 to 40 mg per kg. And for mood disorder, initial dose of valproate is 20 to 30 mg per day, and maximum dose is 60 mg per day. The next drug is lamotrigine, which comes under the class phenyltriazine. Unlike some other psychotropic agents used to treat bipolar disorder, lamotrigine does not destabilize mood or cause sexually adverse effects, weight gain, or withdrawal symptoms. Lamotrigine may cause mild stimulation and insomnia, which can be managed by shifting most of the dose to morning or early afternoon. Principally used in focal onset tonic-clonic atypical absence, myoclonic, and Lennox-Gastaut syndrome. It acts by inhibiting voltage-gated sodium channels and suppressing the release of glutamate. Its half-life is about 24 hours. If given with enzyme inducers, its half-life is 14 hours, and if given with valproate, its half-life is 59 hours. The next Now for dosing of lamotrigine in seizure disorder, for adults it is 150 to 500 mg per day, and in pediatrics it's 5 to 15 mg per kg. In mood disorder, initial dose for first 2 weeks is 25 mg per day, and for the third and fourth week, it's 50 mg per day. After 50 mg per day, dose is increased every week depending on the therapeutic response. The next drug is carbamazepine, which comes under aminostilbene. Although carbamazepine is structurally similar to tricyclic antidepressant impiramine, but it does not have any antidepressant effect. It effectively treats mania and stabilizes mood in bipolar disorder, and principally used in tonic-clonic and focal onset seizures. It acts by prolonging inactivation of voltage-gated sodium channels and blocking voltage-gated calcium channels. Its half-life is about 10 to 17 hours. For seizure disorder, we give 600 to 800 mg per day or 15 to 35 mg per kg in adults, and in pediatrics 10 to 20 mg per kg. In mood disorder, the starting dose is 200 mg per day and the maintenance dose is about 1000 mg per day. The next drug is topiramate, which is a newer drug. Topiramate may improve mania and stabilize mood in bipolar disorder. It may help to treat binge eating disorder and to reduce aggression and other behavioral disorders. Principally used in focal onset tonic-clonic and Lennox-Gastaut syndrome. It acts by stimulating GABA alpha activity and reducing glutamate activity. Its half-life is 20 hours on immediate release and 30 hours on extended release. Its dose is 200 to 400 mg per day in adults and 4 to 6 mg per kg in pediatrics or in children. The next drug is phenytoin, which is a hydantoin drug, once promoted as an antidepressant, but now is rarely used as a psychotropic agent. Some patients may experience sedation, psychomotor slowing, mild cognitive impairment, and depression. An acute encephalopathy and seizures may develop if phenytoin level exceeds 35 mg per ml in blood. Principally used in tonic-clonic and focal onset seizures, it acts by blocking voltage-dependent membrane sodium channels. Its half-life is about 24 hours with dose-dependent variation. For adults, we give 3 to 6 mg per kg in seizure, and for child, we give 4 to 8 mg per kg. The next drug is gabapentin, which is a cyclic GABA analog. For social phobia and other forms of anxiety are effectively treated with gabapentin. It is effective for bipolar or unipolar depressive disorder. Principally used in focal onset seizures, it acts by inhibiting calcium influx and subsequently releasing excitatory neurotransmitters. Its half-life is 5 to 9 hours, and its dose in seizure disorder is 900 to 2400 mg per day in adults and 25 to 35 mg per kg in children. The next is ethosuximide, which is a succinimide, principally used in absence seizures and acts by blocking low voltage activated T-type calcium channels. Its half-life is 60 hours in adults and 30 hours in child. The dose for adults is 20 to 40 mg per kg, and for children is 20 to 30 mg per kg. The next are barbiturates like phenobarbital. Barbiturates are rarely used as psychotropic agents. They possess anxiolytic, sedative, hypnotic, and mood stabilizing properties. It can impair cognition and motivation, depress mental and physical energy, as well as mood, and cause hyperactivity, irritability, aggressive behavior, and impotence. Studies showed that barbiturates are most likely to cause depression and suicidal ideation in patients with a family or personal history of affective disorder. Principally used in tonic-clonic and focal onset seizures, acts by prolonging and potentiating the action of GABA on GABA receptors. Its half-life is 90 hours, and its dose in adults is 60 to 180 mg per day. And for child less than 5 years, its dose is 3 to 5 mg per kg, and 2 to 3 mg per kg in children more than 5 years. My references are from Harrison's Manual of Medicine, 19th edition, and some articles. Thank you.
Morning, everyone. Myself Rahul Singh Batwal, and my topic for today is parental formulation in psychiatry. My moderator is Dr. Arpita Negi, ma'am. Uh, Parental formulation are the formulation which we give through IM, IV, or uh, subcutaneous routes. The first one are the antipsychotics, in which we have firstly discussed about the first generation antipsychotics, also known as dopamine receptor antagonist. The indication for dopamine receptor antagonist are acute psychotic episodes in schizophrenia and schizoaffective disorder, maintenance treatment in schizophrenia and schizoaffective disorder, mania, depression with psychotic symptoms, delusional disorder, borderline personality disorder, and substance induced disorder. The dopamine receptor antagonists used are chlorpromazine, which come in the doses of 10, 25, 50, 100, and 200, which are given as the acute of 100 to 1600 mg, and then maintenance of for 50 to 400. Then there is flumenazine, which is also given the acute dosage of 2.5 to 40, and then the maintenance dosage of 1 to 15 IM. There is also haloperidol, which is also given intramuscular, which is dosage of 5 to 25 mg. The second generation antipsychotics are known as serotonin dopamine antagonists. The uses are schizophrenia and schizoaffective disorder, mood disorder, and off-label indication include immunodeficiency, AIDS, dementia, autistic spectrum disorder, Tourette disorder, Huntington disease, and Allen syndrome. The commonly long-acting antipsychotic drugs are epiprazole, which is given monthly. Ma'am, epiprazole. The first one, ma'am. Epiprazole. Epiprazole, which is given long-acting, which is given monthly. The second one is Fluped, Decorate, which is given 2 to 4 weeks. The third one is Valproate, which is given in the injection form known as Valproate sodium. The trade name is Tepacon injection, which is the time to peak is 1 hour. Then there is antihistaminics, which is treatment for neuroleptic induced Parkinsonism. Treatment for neuroleptic induced Parkinsonism, neuroleptic induced acute dystonia, neuroleptic induced akathisia. There are some antidepressants which are also given. The intravenous citalopram following हम पूछे या दिख साहब citalopram following maintenance oral citalopram may be clinically used for treatment strategy for severely depressed hospitalized patient. Mirtazapine is also as an IV preparation which is administered by slow infusion at dose of 15 milligram. मैम ये mostly infusion at dose of 15 milligram a day for 14 days in 2 studies. Then is amitriptyline, which appear in both IM and IV. IM injection is also given IV. Ma'am, treatment for post-operative pain and depression. Then is clomipene is probably the most widely studied IV antidepressant. Ma'am, the benzodiazepine, which is also in alcohol depression withdrawal. It is also given in anxiety disorders, which reduce pathological anxiety, agitation, and tension, and also used in substance abuse. Ma'am, following are the references used in the slides. Thank you.
Good morning, everyone. I am Dr. Ashika Upadhyay. My moderator is Dr. Neetu Garg. I am going to present on the topic pre-operative evaluation in ECT. So let's start with pre-ECT assessment. Goal of this assessment is to identify and reduce risk to the patient from ECT and general anesthetics, history of previous anesthetic procedure, family history of complications during anesthesia, for any medications taken and allergies. Further investigations based on history and examination findings have to be taken, and ESA physical status classification should be recorded, venous thromboembolism assessment, and pregnancy test completed if appropriate. An ECG performed in all cases with renal function test, liver function test, and full blood count and urine chemistries, and a chest X-ray. Any comorbidities should be informed that can increase anesthetic risk. A psychiatric assessment should be conducted. History of previous response to ECT treatment should be recorded and mental state assessed. Test for baseline cognition function should be conducted. A dental examination to assess the state of patient's dentition who have inadequate dental care. An X-ray spine needed if spinal disorder is seen. CT and MRI should also be performed if there is a suspect of presence of a seizure disorder or space-occupying lesion. This is a pre-ECT evaluation pro forma. We have to fill name, age, father's or spouse name, gender, unit, ICD code, past history of ECT, response to ECT. ECT is prescribed because adequate doses and duration of drug therapy failed, cannot afford to wait for drug effects, drug compliance, drug intolerance, ECT was effective earlier or not, ECT is chosen as first-line treatment, ECT is needed to augment drug therapy, reason for discontinuation of ECT, First, electrode placement. Second, stimulus doses. Electrode placement can be unilateral, bitemporal, or bifrontal. Mostly that is bitemporal. Stimulus doses, threshold 1.5 or 2.5. Then consent for ECT. Clinicians must explain both beneficial and adverse effects and alternative treatment. The informed consent process should be documented in the patient's medical record and should include a discussion of the disorder, its natural course, and the option of receiving no treatment. Printed literature and videotapes about ECT may be useful in attempting to obtain genuinely informed consent. The use of involuntary ECT is rare today and should be reserved for patients who urgently need treatment and who have a legally appointed guardian who has agreed to its use. This is a declaration of consent for ECT. Then concomitant medications. Patients' ongoing medications should be assessed for possible interactions with induction of seizure, for effects on the seizure threshold, and drug interactions with the medications used during ECT. Most antidepressants except bupropion, monoamine oxidase inhibitors, and antipsychotics are acceptable. SSRIs may decrease seizure threshold. Higher doses of venlafaxine may cause hypertension. Most antidepressants except bupropion, monoamine oxidase inhibitors, and antipsychotics are acceptable. SSRIs may decrease seizure threshold. Higher dose of venlafaxine may cause hypertension. Benzodiazepines should be withdrawn because of their anticonvulsive activity before 24 hours for ECT. Lithium should be withdrawn because it can increase post-ictal delirium and can prolong seizure activity. However, lithium can be safely combined with ECT. Post-ECT recovery can be delayed in people with high lithium levels. The combination of antipsychotics and ECT may have a synergistic effect in schizophrenia. Lignocaine should not be given during ECT as it increases the seizure threshold. Theophylline is contraindicated because it increases the duration of seizure. Rizapine is also contraindicated because it further compromises the respiratory and cardiovascular systems during ECT. Pre-medications, anesthetics, and muscle relaxants. Patients should not be given anything orally for 6 hours before treatment. Just before procedure, patient's mouth should be checked for dentures and other foreign objects, and IV line should be established. A bite block is inserted in mouth just before the treatment to protect patient's teeth and tongue during procedure. Except for the brief interval of electrical stimulation, 100% oxygen is administered at a rate of 5 liters per minute during the procedure until spontaneous respiration returns. Emergency equipment for establishing airway should be immediately available in case needed. Anesthesia. Administration of ECT requires general anesthesia and oxygenation. Depth of anesthesia should be as light as possible to avoid elevating seizure threshold. Methotrexate 1 milligram per kg IV bolus is the most commonly used anesthetic as it has shorter duration of action and lower association with post-ictal arrhythmias than thiopentol. 4 other anesthetics are etomidate, ketamine, L-fentanyl, and propofol. Etomidate is sometimes used because it doesn't increases the seizure threshold. Ketamine is sometimes used because it doesn't increases the seizure threshold, although its use is limited by the association of psychotic symptoms with emergence from anesthesia. L-fentanyl is sometimes co-administered with barbiturates to allow the use of low dose of the barbiturates anesthetic, although its use can increase incidence of nausea. Propofol 0.5 to 3.5 milligram per kg IV has anticonvulsant properties. This is the pre-anesthetic evaluation sheet which I have to fill. Then muscle relaxant. After the onset of anesthetic effect, usually within a minute, a muscle relaxant is administered to minimize the risk of bone fractures and other injuries resulting from motor activity during the seizure. It is given to produce profound relaxation of muscle, not necessary to paralyze them, unless the patient had history of osteoporosis and spinal injury. Succinylcholine is usually administered in a dose of 0.5 to 1 milligram per kg as an IV bolus or drip because succinylcholine is a depolarizing agent. Its action is marked by muscle fasciculations which move in rostrocaudal progression. The disappearance of these movements in the feet indicates maximum muscle relaxation. In some patients, tuberculin 3 milligram IV is given to prevent myoclonus and increase in potassium. If a patient has known history of pseudocholinesterase deficiency, atracurium 0.5 to 1 milligram per kg IV can be used instead of succinylcholine. In such patients, the metabolism of succinylcholine is disrupted and prolonged apnea may necessitate emergency airway management. In general, because of short half-life of succinylcholine, the duration of apnea after its administration is generally shorter than the delay in regaining consciousness caused by anesthesia and the post-ictal state. And these are the references. Thank you.
Morning everyone, my name is Rajat Bansal, my moderator is Dr. Vijit Bose. My topic is lamotrigine. Lamotrigine is an anti-epileptic drug of phenyltrazine class. Now it is also approved as a mood stabilizer, mostly in bipolar affective disorder in severe depression. Available as brand name Lemtec, Lamictal and Lamides. Pharmacokinetics, its half-life is 28 to 30 hours. Bioavailability is 98%. It is completely absorbed from GI tract and is metabolized primarily by glucuronidation in liver. Plasma Cmax occurs from 1.4 to 4.8 hours. It acts as voltage-sensitive sodium channel blocker, calcium channel blocker, thereby stabilizing neuronal membrane and modulating presynaptic release of excitatory amino acids like glutamate and aspartate. Indications. It is used in generalized tonic-clonic seizures, myoclonic seizures, partial seizures. It is used as adjunctive therapy in patients of age more than or equal to 2 years and as monotherapy in patients of age more than or equal to 16 years. It can also be given in pregnancy, Lennox-Gastaut syndrome, bipolar disorder. It is not given in acute mania, given in acute bipolar depression. It cannot be given in emergency as bolus dose can cause Stevens-Johnson syndrome. Dosage. Initially given as 50 mg per day for 2 weeks, increased to 50 mg twice a day for 2 weeks, increase in increment of 100 mg per day each week up to a maintenance dose of 300 to 500 mg per day, divided in 2 doses. Dose should be decreased in case of renal impairment and hepatic failure. Adverse effects. Ataxia, insomnia, diplopia, nausea and vomiting, dizziness, Stevens-Johnson syndrome, headache, anxiety. Black box warning is given along with lamotrigine as it can cause life-threatening rashes including Stevens-Johnson syndrome, toxic epidermal necrolysis or rash-related death. The rate of serious rash is greater in children. Stevens-Johnson syndrome is characterized by facial swelling, tongue swelling, red or purple skin rashes that spreads within hours over the skin and mucous membrane. drug interactions. Valproate increases its concentration by 2 times, so doses should be reduced to half. Carbamazepine, phenytoin decreases its concentration by 40%. Osupiz and rifampicin also decreases its concentration. Its toxicity can cause coma, conduction abnormalities, and death. These are the references.